So everybody has about 1.5 minutes. And I'm just I think I forgot to introduce myself. I'm Dr. Mona Gupta. I'm one of the co-chairs of the Research Showcase. So the first presenter is Jude. I don't know if I'll pronounce the last name right, Ezechukwu. I'm sorry if I pronounced it wrong. Jude, are you here? Okay, I'm going to move on to the next one. Neha Chalu, are you here?
Hi, yes, I'm here.
Hi, Neha, please go ahead. If you want to share your screen, please feel free.
Okay. It's saying I can't share my screen.
Mayank, can you help, please?
You must be having seeing one tab on your screen. There's a green share screen button.
When I click the green share screen button, it says host disabled participant screen sharing.
Let me help you. Now you can see.
Okay. Hi, everyone. My name is Neha Chalu. My project is titled the Experimental Design of Subcloning and Identification of the IL-10 gene to determine its role as a disease marker of human heart failure. Currently, 40 million people around the world suffer from heart failure, and over the past couple of years, researchers have identified several genetic polymorphisms that increase or decrease heart failure susceptibility. The goal of this project is to design a flexible yet thorough experimental protocol that tests the varied expression of a candidate gene across a control and treatment group to learn whether in fact the gene is connected to heart failure etiology. I used a variety of lab manuals, biotechnology softwares, and molecular protocols to tailor an experimental procedure to the IL-10 gene. As evident in the images in the middle, the procedure is divided into 4 main parts: identification of the candidate gene, overexpression of the gene in a vehicle vector, treatment of the cardiomyocytes using the overexpressed vehicle vector, and analysis of any changes to the cardiomyocytes. Using the method provided here, protocols for other suspected candidate genes relating to heart failure can also be designed. In the future, follow-up studies could examine the precise relationship between the IL-10 polymorphism and heart failure to determine its role across different patient populations. Thank you so much for your time.
Mona, you're muted. This is Harneet.
Sorry, thank you, Harneet. Thank you, Neha. That was very nice and very timely. You know, you finished on time. Next, I would like to call Vineet Tatineni.
Yeah, present. Let me try to share my screen.
Sorry to interrupt. Ms. Neha, can you make me host again? By mistake, I make you host. Neha?
How would I make you host?
By like, have you seen? Can you see the participant list?
Yeah.
And by clicking more button, you can.
The more button, would that?
By clicking on my name.
Yeah.
You see
Okay, I see it. Sorry. Okay.
Thank you. Yes, ma'am. You can continue.
I'm not able to share my screen.
Give me 1 second. I'm helping. Can you try once again?
Yeah,
Yeah.
let me see. Is it working now?
Yeah.
Okay. So my name is Vineeth Tatanini, and my project's titled Site Sequencing to Identify Increased Immune Activation in Patients Treated with Nivolumab and Bevacizumab in randomized phase 2 study for recurrent glioblastoma. So our project involved looking at glioblastoma microenvironments and differences in gene expression depending on therapy. Glioblastoma is the most common, most lethal primary brain tumor. There's been a big recent push towards the use of immunotherapies, such as anti-PD-L1 inhibitors for treating tumors. However, previous clinical trials have shown only an 8% response rate with nivolumab for treating glioblastomas. So we wanted to look at glioblastomas and see how it creates an immunosuppressive environment. And if we added an anti-VEGF medication, if it would cause immune activation effects, which would synergistically help anti-PD-L1 medications. So in our trial, we had 8 patients that responded and 8 patients that didn't respond. And we also split them up to patients that took standard dose of Avastin and patients that took low dose of Avastin. We then performed genetic cellular indexing and analyzed the differences between the cohorts. Our data showed that the standard dose of Avastin cohort responded more than the low dose of Avastin cohort, and the standard dose of Avastin cohort significantly reduced myeloid-derived suppressor cells and caused an immune activated state. So we believe these results show that immune activating effects of the anti-VEGF may work synergistically to help gliomas respond better to anti-PD-L1 medications. But further analysis needs to be completed comparing immune populations of standard dose of Avastin control group to this combination group that we used here.
Mona, you're muted.
Please
You're
unmute.
muted, Mona.
Sorry. Thank you, Vineeth. That was very nicely presented. Next, I'd like to call in Aditya
Hello,
Kalahasti.
Mona. Hello, Mona. I was the first guy you called. I had problem logging in. Jude Ezechukwu. Can I present? I had problem logging in.
Absolutely, Jude. You can go next.
Okay. Can you allow me to share my screen?
Yes, yes, yes.
Seems like someone is still sharing screen. Okay. I can't share my screen. Sorry.
Please try.
Okay. Yeah, I can try right now. Just a minute. Okay, so this is just a brief case of septic Ebola in a patient, a drug addict who came in with fever, chills, and rigor. So this is a 26-year-old Caucasian female who presented with just 1 week history of pleuritic chest pain, malaria, chills, and fatigue, and some chronic forearm lesion due to IV drug abuse. She has past medical history of hepatitis C and also IV heroin abuse. When she presented, she was very febrile, hypotensive, tachycardic, and also tachypnic. And she had multiple injection marks in both arms and also in the legs. So the lab showed leukocytosis with very significant bandemia and lactic acidosis. We diagnosed her with septic shock, started IV hydration, collected samples for, for blood culture, and also gave her some broad spectrum antibiotics. The chest X-ray and the CT angiogram that was done showed some bilateral cavitated nodular opacities that was very suspicious for some septic emboli. So we did an echo, and echo showed very huge vegetations in both the mitral and the tricuspid valves. Of course, we made a diagnosis of infective endocarditis with complications of septic emboli, and we transferred the patient to another facility where she died from multi-organ failure. So basically what we wanted to actually use this topic to show was that septic emboli can also occur as a complication of another complication. So infective endocarditis is a complication of IV drug abuse and can be complicated by septic emboli, in which this emboli can be lodged in different organs and cause a whole lot of things like stroke, myocardial infarction, and in this case, it was in the lung. So this is kind of a case of septic pulmonary embolism. That is as a complication of the infective endocarditis of the patient. Thank you.
Thank you, Jude. The next is Aditya Kalahasti.
Hi, are you able to hear me properly?
Yes, we can hear you.
All right, let me go ahead and share my screen. Are you able to see the screen pretty properly?
Yes, we can see your screen.
All right. So the project I essentially had focused on the role of TNF alpha, which is a pro-inflammatory agent in the role of microglial cells, which essentially function as immune agents within the brain. Now, specifically, microglial cells are macrophages, which serve as agents of immune responses within the brain. TNF alpha, similarly, is a pro-inflammatory molecule which essentially stimulates inflammation with microglia. Now, the project title here is Analyzing Patterns of Gene Expression in Inflamed Microglia Stimulated with the Pro-Inflammatory Molecule, that is to say, TNF-alpha. Essentially, the samples used of microglial cells were divided into four. There are two broad categories. First, with an overexpression of the NR8-2 gene, which controls an inflammatory response in microglial cells, and a second group which did not have an overexpression of NR8-2. Now, within each of these two samples, there was a group treated with TNF-alpha as well as a group that was not treated. Now, the procedure used here was essentially using the RNA sequencing program seqmonk, where I created an interstitial probe to essentially go through the 23 human genes to mark areas of high expression from the proteins from the NR8-2 gene. And as you can see here in this bottom diagram, it essentially shows that the samples that were not treated, that did not have a higher expression of NR8-2, actually showed a higher level of gene and protein expression. Essentially, in the conclusion, in the comparison of these samples found, the presence of TNF-alpha resulted in a high differentiation of genes, and the overexpression of the NR8-2 gene actually resulted in a much lower level of differentiation, which was not expected. Overall, this means that when untreated with the tumor necrosis factor, or the TNF-alpha, and when unmanipulated with the NR8-2 gene, there's a higher level of expression in regards to genes in the inflamed microglia. This project has a lot of application when you look at cerebrovascular diseases, as well as major neurodegenerative diseases such as Alzheimer's.
Thank you, Aditya. Next is Zain Alshenhablay. I'm sorry if I pronounced your name wrong. Zain, are you here?
Yes, I'm here. Hello, can you hear me?
Yes, we can hear you.
Okay, I'm going to share my screen. I can't share the screen.
Give me a second. Now you can try, yeah.
Okay. Can you see it?
No.
Okay, give me a moment. It's loading. Can you see it now? Hello?
No.
No.
You know, I'm 1 second. I'm trying to. I don't know why. I can't see. Can anybody see her screen?
Actually, maybe now you can.
Yes. Yes.
Okay. So hi everyone, my name is Zainal Shinabli. I'm gonna talk about case of myxedema coma. Here I have an 81-year-old female with past medical history of primary hypothyroidism who presented with a 1-week history of altered mentation. And during that week, she was unable to consume her medications. On physical exam, when she came in, she was hypothermic with a temperature of 34.7, and she was disoriented, along with signs of congestive heart failure. She soon developed cardiogenic shock and respiratory failure requiring intubation and mechanical ventilation. Her labs showed a very high TSH level of 103 and a free T4 that was very low. Her chest X-ray was congested, and an echocardiogram revealed a very low ejection fraction of 25 to 30% with pericardial and pleural effusions. Therefore, the diagnosis of myxedema coma with cardiopulmonary failure was made, and she was started on IV levothyroxine, IV steroids, and the appropriate cardiopulmonary support. Going to discuss briefly cardiovascular hemodynamics of thyroid hormones. Thyroid hormone causes a decreased resistance in the peripheral arterioles via direct smooth muscle relaxation. And this activates the RAS system, which increases sodium absorption. Thyroid hormone also increases the resting heart rate contractility and erythropoietin synthesis. These changes altogether cause an increase in the preload and reduce afterload, which increases the cardiac output eventually. In hypothyroidism, cardiac output may decrease by 30 to 50%, and this is how patients with myxedema coma can present with acute heart failure. Thank you.
Thank you, Zain. Next is Sukumar Gundapaneni. Sukumar, are you here? I'll move on to the next person, Harsha Adnani.
Yes, I'm here. I'll just share my screen. Can you all see my screen?
Yes.
Hello? Okay.
Yes,
So,
we can see
hi
your
everyone, my
screen.
name is... All right, great. Hi everyone, my name is Harsha Adnani, and my topic is HIV-induced podocyte pyroptosis contributes to PEC proliferation. So we did this research on HIV-associated nephropathy, which is basically characterized by collapsing glomerulopathy. We show that in the earlier studies that the podocytes and PECs they come from the same origin, but actually they have a crosstalk between each other. So we are trying to do a pyroptosis study here, showing that the outcomes of the pyroptosis, which is IL-1 beta and IL-18, interleukin-1 beta and interleukin-18, cause the swelling of the cell, releasing these cytokine kind of molecules which disrupt the outside kidney structure. So our role is to determine that. So we conducted many experiments based on the time dose manner of taking the cells as culturing them with IL-1 beta and IL-1 beta and IL-18. And we found that as we increase the time and the concentration of the cells, the number increased. And the IL-1 beta antibody, which got inhibited once we combine them with antibodies and IgG, showing that there is an inhibition of the PECs once you combine them with the antibody. Then we did subsequent experiments with immunofluorescence and immunohistochemistry, marking the cells and the tissues for podocyte markers by IL-1 beta, ASC, which is apoptosis-like molecule, an NLRP3 molecule here, and in FABN mice and in TG26 mice. And then we confirmed that by co-labeling with nephrin and caspase-1, and then we conducted merged studies with them showing that in FABN mice, you can see the podocyte markers and then you cannot see them in TG26, showing that there is a crosstalk between IL-1 beta and in PECs and podocytes. In summary, we concluded that HIV infection of podocytes is contributing to the parietal epithelial cell proliferation via induction of apoptosis and generation of IL-1 beta. Thank you.
Thank you, Harsha. Next is Andrew Alijo. Andrew,
Yeah,
are you
I'm here. Yep. Okay. Hello, everyone. My name is Andrew Laiho, and I'm a first-year medical student at NeoMed, and I'm doing research under Dr. Faiz Fadi. So over the past few months, we've been working on this project, a novel regulatory role of L-plastin in IL-1 beta mediated inflammation in human chondrocytes. So osteoarthritis is the most prevalent joint disease worldwide. It's the wearing down of cartilage in your joints that gradually worsens over time. In the US alone, there are more than 3 million cases per year that account for $16.5 billion in hospitalizations. L-plastin is an actin bundling protein essential for actin regulation in multiple cell types. It was reported that L-plastin was elevated in rheumatoid arthritis. Therefore, we hypothesized that L-plastin might also be a regulator for inflammation in osteoarthritis. Our methods included human chondrocyte cell culture treated with IL-1 beta, which causes inflammation similar to osteoarthritis, and L-plastin inhibitor, which was then measured for the gene expression of those pro-inflammatory markers shown in figure 2. In addition, we had an ex vivo mouse femoral head organ culture. So what we saw that L-plastin gene expression being upregulated after IL-1 beta treatment, and the human chondrocytes showed downregulations of those pro-inflammatory markers after being treated with 1 dose of L-plastin inhibitor. In the mouse femoral heads, we saw L-plastin inhibitor reversing the matrix degradation shown in figure 3 that the IL-1 beta caused. So we believe that by inhibiting the L
We can't hear
plastin, Is that it? Is that good?
Andrew, yeah, in between we lost you, but yes. Are you finished with your presentation?
Yeah, that was it.
Okay, thank you, thank you. Next is Krishnendu Khan. Krishnendu, are you there? Then move on to next. Next is Jude. You have another one?
Yeah, I have another one. Oh, just give me a minute. Let me share screen. No, wrong screen. Just give me a minute. I will pull it up. Okay. So can you see my sharing? Okay. So here we go again with a case of herpes meningitis. So this is titled herpes is here again in my head. Can you hear me?
Yeah, we can hear you.
Okay, so this is a case of malarial meningitis, which is a kind of a benign recurrent aseptic meningitis that is marked with 3 to 10 episodes of fever and meningism lasting for a few days and followed by spontaneous recovery. So we have a case of a 52-year-old African-American female who presented with a 2-day history of severe global and throbbing headache.
Jude, sorry to interrupt you, Jude. We don't see your poster.
You can't see the screen I'm sharing?
Yeah, I can see the screen you're sharing, but it doesn't have the poster. Is that what you want to show?
Oh, yeah, that's what I want to show.
Okay, that's good then.
Okay. So the case of moderate meningitis in a 52-year-old African-American female who presented with a 2-day history of severe global and throbbing headache that was associated with neck stiffness, nausea, vomiting, fever, photophobia, chills, myalgia, and lightheadedness. So this patient has been admitted twice in the past with almost similar presentation, and she had similar presentations in the past without presenting to the hospital. So physical examination was significant for painful distress, stiff neck, and also a positive Koenig sign. The CBC showed leukocytosis and brain CT was normal. When we did a lumbar puncture, the CSF analysis showed total nucleated CSF cell count of 556 per millimeter cube. 52% of these were neutrophils and 47% were lymphocytes, showing possible aseptic meningitis. So the CSF protein was elevated at 197, while the CSF glucose was normal. A PCR of the HSV2 DNA was positive. So a patient was diagnosed with moderate meningitis, given that this patient had had similar presentation up to 3 times. And we started a cyclovir, and patient attained complete resolution on the 4th day of the admission, and we discharged patient later. So the discussion and the teaching point in this case is that this moderate meningitis, which is usually caused by HSV2, is a kind of benign recurrent meningitis, is self-limiting, and with or without acyclovir or antiviral, patient will still recover fully. So this is just to highlight a case of very benign meningitis that doesn't really need a whole lot of investigations or treatment to at least save the patient the panic and also the complications coming from treatment. And it has been shown that even acyclovir or valacyclovir doesn't prevent these recurrent types of meningitis. Okay, thank you.
Thank you, Jude. Next is Shiv Shankar Verma. Shiv Shankar, are you there? I'll move on to Spencer Lin. Spencer?
Hi, I'm here. Can you hear me?
Yes, we can hear you.
Okay. Hi, so my name is Spencer Lin, and my presentation is on the enhanced synergistic efficacy of simvastatin plus metformin on abiraterone-resistant prostate cancer cells. In the United States, prostate cancer is the second most common cancer in men, and androgen deprivation therapy has become the most common treatment for advanced stages of prostate cancer. However, while this treatment is effective initially, about 30% of prostate cancer patients will stop responding to this treatment and as a result develop castration-resistant tumors, which respond poorly to chemotherapy and other treatments. In this study, we were testing a combination treatment of simvastatin plus metformin on prostate cancer cells that were resistant to an androgen receptor agonist abiraterone. So looking at figures 1 and 2, you can see how the C42B ABI cells were not significantly inhibited by abiraterone treatment. However, in figures 3 through 6, we can see that the combination of sim plus met do inhibit cell growth in these abiraterone resistant cell lines. This suggested that a combination therapy could be an effective and inexpensive alternative to chemotherapy for patients with cancer that has developed resistance to abiraterone. Thank you.
Thank you, Spencer. Next is Rahul Jain.
Yep. 1 second. Can you see it?
Yes, we see it, Rahul.
All right. Hi, my name is Rahul Jain, and today I'll be talking about examining peripheral immune cell phenotypes in non-small cell lung cancer patients undergoing chemoimmunotherapy. As shown in figure 1, some tumor cells mask themselves by displaying PD-L1 on their cell surface, Immune checkpoint inhibitors are antibodies that prevent PD-1 receptors on the T cell and PD-L1 on the tumor cell from binding. This has been proven to be an effective way to mount an anti-tumor response. Combination of chemotherapy and immunotherapy shown in figure 2 has been shown by various clinical trials to be a more effective treatment than single agent regimens due to their combined anti-tumor effects. We aim to investigate any relationship between chemotherapy, immunotherapy, and immune cell phenotypes to identify early indicators to anti-tumor response. We hypothesize that responders will demonstrate a prevalence and activity of immune cells distinct from that of non-responders. These differences will allow for early detection of therapeutic efficacy, and a literature search was performed to investigate current research on the topic. The trial done by Griffiths et al. Yielded the following results for non-small cell lung cancer patients. In figure 3D, you can see that there is an overall increased number of PBMCs following chemoimmunotherapy, unlike the non-responders. As shown in figure 3E, the responders to the treatment demonstrated a much higher immune population regulation of tumor growth toward the second half of the trial as compared to the non-responders. There were also noticeable differences in CD4 and CD8 T cell populations through the therapy. Using blood testing and immune cell analysis through RNA sequencing and flow cytometry, it was found that there were distinct immune cell phenotypes between patients who responded to the chemoimmunotherapy and those who didn't. Further study is required. The proposed clinical trial in figure 4 shows similarities to past trials done by Griffiths et al. And can prove valuable to further study. Thank you for your time.
Thank you, Rahul. Next is Giovanna Leon.
Hi.
Giovanna, hi.
Yeah. Hello. Can you hear me?
Yes. Yes.
Okay. All right. I'll screen share right now. Okay. Are you able to see?
Yes.
Okay. Hi, everyone. I'm Gia. I'm a current M2 student at NeoMed. I'm going to talk about the role of sex steroids and irisin's neuroprotective effect today. So, as many of you know, Alzheimer's is a devastating neurodegenerative disease affecting 5.4 million Americans. There are no available disease-modifying treatments currently available, and the process progresses by amyloid plaques and neurofibrillary tangles that accumulate in the brain and essentially kill neurons. Preliminary data from our lab suggests that hormone irisin may protect the brain from this pathological process. 1 month of weekly irisin treatment reduced neuropathology in female mice, but not male. This next study we are conducting is currently ongoing, and we're interested in the reason for this particular gender difference. And explaining this project simply, we basically performed bilateral ovarectomies on female H-tau mice to determine irisin's effects on p-tau protein expression through protein quantification. And we hypothesized that the sex steroids might make a difference in irisin's neuroprotective effect on these mice. They might reduce or eliminate the protective effect. And some things to hopefully learn in the future based on this ongoing study are the female sex steroids the key difference in irisin's neuroprotective effects in these mice? And does the age-related decline in estrogens in women negate the potential therapeutic effects of irisin as a clinical Alzheimer's treatment? If you have any questions, just let me know.
Thank you, Giovanna. Next is Pooja Jeet Khera.
Hi, I'm here. Can you hear me?
Yes, we can hear you.
I'll share my screen. Can you see my screen?
Yes.
Okay. So I'm Pujajit Kaira, and I'm an M3 from NeoMed. And today I'll be talking about a quality improvement project that I was involved in at Access Point Community Health Centers, specifically the ones at Barberton and Kent. So I worked with a family medicine doctor who specialized in addiction medicine, and he specifically did treatment for like addiction, so like medication assisted treatment, also known as MAT or MAT. And he specifically used Suboxone or Vivitrol, but he explained to me how it's really important to make sure that his patients are doing other things in their life to maintain a healthy lifestyle so that relapse can be prevented, because if patients are just using those drugs, they tend to have more relapses. So he explained that like things that cause a healthy lifestyle include exercise, healthy diet, good sleep hygiene, and making sure that they're not socially isolated, so that they do things such as like Narcotics Anonymous or go to counseling or something like that. And especially with sleep hygiene, a lot of them, because they're addicts, have problems going to sleep. So there are other things like they sometimes like tend to use like opioids to help them sleep. So they have to find other ways to help them instead of using drugs. So there I created a pamphlet about tips of helping them like live a healthy lifestyle. And then I also created a questionnaire to help the patient cares team determine if they were living a healthy lifestyle outside. So I'd ask them things like if they have a healthy diet, if they're not using electronics before they sleep, if they have a counselor, if they're going to NA, or if they're doing exercise like 5 times a week. And this was really helpful because otherwise there would have been no way for the medical team to know if the patient was having a healthy lifestyle outside. And so they found it really useful, and that was my project. Thank you.
Thank you, Pujajit. Next is Josh Weiner. Josh, are you there?
Hey, I'm here. 1 second. This is my helper, Anthony Miauchi. 1 sec. All right, so hi, my name's Josh Weiner. I'm an internal medicine intern at University Hospitals Cleveland Medical Center. Very fortunate to get to work with Dr. Gupta. So essentially, the COVID-19 pandemic has created new barriers for the delivery of healthcare. A lot of this is related to limiting healthcare worker exposure while also conscientiously conserving PPE. So this necessitates the development of creative solutions to meet the needs of our patients without sacrificing any care. Working with terminally ill patients, the Department of Palliative Medicine at UHCMC has instituted a hybrid in-person telehealth model. This has enabled the IDT team to continue to work while reducing the exposure of the team members while also conserving PPE. The importance of doing this is exemplified in this example case here, which is one of over 300 combination visits that has been performed by members of the team. In this case, a 73-year-old woman with acute decompensated liver failure presented to the hospital after a recent 9-week stay at an outside hospital for fluid overload status and care. At that time, I initiated with Dr. Gupta goals of care discussion. The patient was amenable to initiating home hospice with comfort care with stated goals of pain management and maximizing time with family. Although her husband initially disagreed with that pretty strongly, but after discussion, he and his wife felt mutually accepting and comfortable with initiating that care. After that, we initiated a hybrid in-person telehealth pastoral care and music therapy visit. Unfortunately, the next day, the patient was found unresponsive and was pronounced deceased. The widower, however, later sent the thank you note with an accompanying mass card. And poignantly, it mentioned that he had created a very nice, lasting, happy memory of that IDT visit, noting, asking us, did you see the look on her face? Did you see how happy she was? And there's numerous other occasions where patients or their family or their loved ones have expressed significant gratitude for being able to continue to perform all the members' functions throughout this pandemic. In conclusion, we've been able to deliver over 300 hybrid in-person telehealth IDT visits, particularly with our pastoral care and music therapist, which are seen here in an example in this photograph. This has enabled us to continue delivering the care so desperately needed by our patients at a very difficult time. And this can continue to be a model that can be adopted by other portions of the hospital, while also continuing to conserve PPE that'll be greatly in need as the surge continues. Thank you very much.
Thank you, Josh. Next is Heba Hussain. Heba, are you there? Or Haren Prabhakaran?
Yes, we're here. I will be share my screen.
Yes, we can see your screen.
Okay, thank you. Okay, hi everyone. Our quality improvement project is called Evaluating the Social Media Boosted Poll Feature for Serving Older Adults in Northeast Ohio, by Hiba Hussein, Harini Prabhakaran, and Dr. Amy Lee, and we're both M2s at NeoMed. Many institutions use social media platforms like Facebook in order to learn more about the populations they're trying to reach out to, and studies have documented that using boosted polls on social media can increase survey response rates because they reach a wider and more targeted audience. The purpose of this evaluation was to see if using Facebook was a useful form of collecting community assessment data in Northeast Ohio, specifically for older adults 65 years and above, and to see if we could generate better response rates by using the boosted poll feature on Facebook. So over 3 weeks, the Lake County Health Department paid $50 per week to have a 3-question survey boosted on their Facebook page, and then Stark County Health Department posted the same questions on their Facebook page without boosting it.
The 3 questions that we asked the participants were: 1, if they were 65 years and older; 2, if the post was at the top of the page; and 3, whether Facebook surveys were a good way to reach them. After 3 weeks, we saw that Lake County's boosted survey had 11.5 times higher participation rates than Stark County's non-boosted survey overall, and 187 times higher responses in the target populations of 65 years and above. In addition, more than half of each county's respondents said that Facebook surveys are a good way to ask them questions. Some limitations for this project include a time frame of 3 weeks, a sample size representing only 2 counties, and not being able to control for how many times a participant could take the survey. In conclusion, boosted Facebook posts are effective for future assessment surveys. Thank you.
Thank you. Next is Jay Natarajan.
Yes, I'm here. I'll share my screen right now. All right, so hello everyone. My name is Jay Natarajan. I'm an M2 at NeoMed, and my project was about the impact of COVID-19 on the SVS VQI arterial procedure registry. So since COVID-19 pandemic started, surgical practices around the nation have been greatly affected. The American College of Surgeons urged surgeons to prioritize emergent surgeries and delay any elective cases. One global study stated that 87% of vascular surgery practices halted outpatient procedures in an effort to minimize contact and save hospital space. The goal of our paper is to assess the effect of COVID-19 on vascular surgery practice volumes, specifically arterial cases. This project was in collaboration with the Society for Vascular Surgery Vascular Quality Initiative, or VQI, which is a nationwide vascular data collection collaborative. We accomplished this by surveying 220 VQI data managers and 105 VQI physicians about their 2020 workflow. We defined arterial cases as peripheral vascular interventions, carotid endarterectomy, endovascular aneurysm repair, and infrainguinal bypass, since these are the most commonly performed arterial procedures. We examined the case volume trend throughout 2020, and we compared 2019 and 2020 trends to check for any similarities. The results are shown in the 2 graphs on the right. Figure 1 shows that all arterial cases declined sharply at week 11. Figure 2 shows that there was a 29.4% decrease in case volume from weeks 6 through 9 to weeks 10 through 13 of 2020, whereas there was only a 4.1% decrease for the same time period in 2019. We attribute this 7-fold decrease in case volume to the COVID-19 pandemic. In addition to revenue loss, we caution that delays in arterial procedures can lead to critical limb loss, stroke, and aneurysm rupture. Our significant limitation was the voluntary nature of our survey. However, after analyzing the geographical distribution of the responses, it was representative of the entire nation. Further research should look into procedure rates for patients with COVID-19 associated hypercoagulation. Thank you.
Thank you. Next is Shiv Shankar.
Yeah.
Shiv Shankar, are you on?
Yeah.
Okay.
Can you hear me now?
Okay, please go ahead.
Can you hear me now?
Yes, we can hear you and we can see your screen.
Okay, thank you very much. So yeah, my poster is about androgen deprivation therapy that induce some transcriptional changes in prostate cancer, and that leads actually to exhibit some stem-like features to the cells. And what we are trying to understand here is like, what are the causes that makes prostate cancer cells resistant to chemotherapy, like the androgen deprivation therapy. So we analyzed through NGS next generation sequencing data, and we found some of the candidate genes like ALDH1, SOX2, and OCT4. These are the potential marker genes that we have identified involved in responsible for developing stemness to the cells. That stemness actually developed resistance against those androgen deprivation therapy. So so this is all the potential marker we have identified. Maybe in future therapy we can use all these to functional validate our experiments more. But in conclusion, our NGS data and functional analysis reveal that metabolic reprogramming in context to solute carrier, in context to stemness of the genes. And these are the promising approach for designing novel therapeutic strategies to circumvent androgen deprivation resistance. Thank you very much.
Thank you, Shiv Shankar. Next is Neha Cello.
Hi. Can you see my screen?
Yes, we can see your, yes, influenza vaccine, yes, we can see it.
Okay. Hi. So my project is titled The Efficacy of the Influenza Vaccine in Hospitalized Children, a systematic review and meta-analysis. Influenza is a global pandemic that affects millions of people worldwide. However, 10 to 20% of children are affected by the influenza each year and are especially susceptible given their young age. I sought to assess the effectiveness of the seasonal flu vaccine in specifically hospitalized children. I did a PubMed search of children with influenza in the inpatient setting, and of the 116 studies, 14 met the inclusion criteria. I conducted this meta-analysis by calculating the Q and I-squared values, which are measures of heterogeneity of these studies, and constructed a forest plot consisting of 95% confidence intervals. The pooled vaccine efficiency ratio ranged from 58 to 80% in different studies. So the I-squared value of 92% indicated a large heterogeneity between these studies. So the first forest plot looks at vaccine effectiveness as a whole, and 10 studies passed the central measure of tendency, which indicates some level of homogeneity. However, the second plot looks at ICU hospitalizations due to influenza, and only 2 studies crossed the central tendency, which indicates a large amount of heterogeneity. So what I concluded was that the effectiveness of the vaccine is somewhat variable in children older than 6 months and under 2 years old. Larger studies are needed to assess the efficacy of the flu vaccine in hospitalized children and not solely the typical adult population. Thank you.
Thank you, Jay. Thank you, Neha. Next is Arul Mehta. Arul, you're muted.
Yeah, I'm here. Yeah.
Yes, we can see your screen.
Okay, sounds good. All right. Okay, so hello everyone, I'm Arul Mehta. I am a senior at St. Ignatius High School, and today I'll be presenting on what the best treatment options are for nutcracker syndrome. So just like the action of a nutcracker crushing a nut, the syndrome refers to when the abdomen's aorta and the superior mesenteric artery compress the left renal vein. Although it's a very uncommon syndrome, it is an essential diagnosis due to the illness, problems, and diseases associated with it. So we use the PubMed database to investigate the association between the syndrome and treatment through endovascular and vascular surgery. And a total of 9 articles were found with information relevant to what
Nutcracker syndrome is, case reports, how it's diagnosed, and how it can be treated. So we presented a case report of robotic-assisted left renal vein transposition to treat a patient with the syndrome. She was a healthy 19-year-old woman presented with a 2-year history of abdominal pain and microscopic hematuria without a discernible cause. And a follow-up CT scan later demonstrated worsening compression of her left renal vein. She experienced an immediate reduction of pain after her surgery, and at her 1 week, 1 month, and 2 month follow-up visits, the patient reported continued improvement in the frequency and severity of her abdominal pain. So my research shows that robotic left renal vein transposition is a safe, effective, and feasible surgical technique to treat Nutcracker syndrome patients, but more studies are needed to determine the ideal treatment for the syndrome. Thank you.
Thank you, Arul. Next is Sanjay Jinka.
Hi,
Sanjay,
can you hear me?
there? Yes,
Yeah.
we can hear you. Yeah.
Perfect. Screen share here. Cool. Can you see that?
Yes.
Awesome. Okay. Well, my name is Sanjay Jinka, and today I'll be discussing our research on what modalities of communication yield the best results for reaching out to donors to support charitable causes like our student-run free clinic. So to determine this, statistical correlation of various factors to response and donation rates was found using data from previous clinic fundraisers. We found when compared to other modes of communication, in-person communication was shown to be more likely to elicit both responses and donations when compared to phone calls and website communication. Internal potential donors, these being donors affiliated with NeoMed or the clinic, were also shown to be more likely to donate when compared to other individual potential donors. Lastly, businesses with decreased spatial distance from the student-run free clinic were significantly more likely to respond. Taken together, this suggests that charitable organizations, namely student-run free clinics, should prioritize in-person communications with known affiliates or spatially close potential donors to maximize donations. These results were employed successfully this past week in a virtual campaign for the clinic, where we were able to raise $21,000, which was over 200% of our original goal, and the clinic's most successful fundraiser to date. Moving forward, I hope to build upon our research to identify further ways to optimize donations for charitable organizations. Thank you.
Okay, thank you, Arul. No, thank you, Sanjay. Next is Jay Patel. Please don't take more than 1.5 minutes. Jay, we can't hear you. I don't know if you're speaking or not.
Okay, can you guys hear me?
Yes, yes.
Okay, sounds good. Okay, hey everyone, my name is Jay Patel. I'm a third-year medical student at NeoMed, alongside Elizabeth Otto, who's also another student, and Dr. James Taylor from Cleveland Clinic. We did a quality improvement project titled Patient Safety Alert, Preventing Infection from the Misuse of Medication Vials. This study highlighted the Joint Commission Sentinel Event Alert number 52, which talked about bloodborne pathogen transmission through the misuse of medication vials. Since 2001, there's actually been 49 outbreaks due to the use of injectables such as Botox. We think these numbers are actually underreported since infections aren't likely to be linked to misuse of medication vials. This alert also highlighted a survey of 5,446 healthcare workers who were asked questions about lapses in basic infection control. 6% of these respondents use single dose vials on multiple patients. 15% actually use the same syringe to re-enter multiple dose vials for the same patient. And then 6.5% of these 15% save multiple dose vials for multiple other patients. We think that reducing waste and cutting costs were likely to be leading reasons for compromising safe control practices.
As a result of this Sentinel event, the CDC released the two graphics that you see on this poster. On the left, they have the recommendations for single dose vials, 1 needle, 1 syringe, only 1 time. And on the right, you see safe practices for multiple dose vials, starting with scrubbing the rubber septum with an antiseptic, allowing it to dry, and then using only 1 needle and only 1 syringe each time you use the multiple dose vial. For our discussion, we talk about recommendations and potential strategies for improvement, including developing evidence-based plans for vial misuse prevention, as well as providing training and education annually to all staff who administer injections, as well as training on recognizing and reporting breaches of safe practice. It's also important to develop a culture of safety, emphasizing that all staff are responsible for reporting risks, errors, and adverse events, as well as creating a culture where the reporting of unsafe injection practices or near misses is viewed as necessary. And finally, when breaches of safe practice are made, notifying the patient and ensuring that the patient receives all testing necessary. Thank you.
Thank you. Next is Anna Cherian.
Hi, yeah, let me share my screen.
Yes,
Okay,
Anna, we can see your screen.
Okay, great. So I assess the prevalence of obesity among food insecure school-age children and family medicine residency practice. So I handed out a survey with a validated 2-question tool and then just basic family demographic data. So we found that there were 72 patients who were food insecure. But between the food insecure and food secure patients, there wasn't a difference between obesity rates. But we did find that there was a gap between our food insecure patients and the food assistance they were receiving. So we determined that we need to connect our families who are food insecure with more resources, and that programs like SNAP and WIC could help mitigate food insecurity within households at risk. I also created a GeoMap which showed that many households with high incomes are also food insecure, which further increases the need for screening for social determinants of health and making sure that we normalize the screening. Thank you.
Thank you. Next is Nicholas. Nicholas, are you there? Yes, please go ahead.
I'm here. Let's see here. Can you guys see my screen here?
Yes, we can see your screen, and all those people who are left, please try to limit your presentation to 1.5 minutes. Otherwise, we will not be able to finish or give opportunity to everybody. So please be mindful of others. Thank you.
All right, so my name is Nicholas Dalianis, and I am a third-year medical student at NeoMed right now. I conducted this research with Megan Tranovich and Dr. Nabil Ibrahim at the University of Toledo, and our paper was titled Teres Minor and Quadrilateral Space Syndrome, a Review. And basically, we conducted this research looking through the PubMed database and trying to compile information basically surrounding the Teres Minor and specifically its involvement in quadrilateral space syndrome. And we found that the anatomy of the syndrome and the pathology behind it really were well understood, but there was a little bit of uncertainty regarding the specific treatment options and plan that should be used when trying to treat this disorder. So we tried to compile the information we found in order to get an understanding of the current practice that is in place for treatment of this disorder. And we found that it really should begin with a treatment using physical therapy, NSAIDs, and really just a conservative approach for about a 6-month period before any consideration for even a surgical approach should be thought. And then once you finally get to that 6-month period, we found that the surgical approach would be surgical decompression of the quadrilateral space and the neurovasculature structures that run through there. And that is found to be a very effective and well-tolerated procedure that we found to be used quite often and really became the gold standard for treatment of this disorder. So that's kind of all I have for that. And thank you for listening.
Thank you, Nicholas. Next is Fariz Hamad. Fariz, are you there? I'm going to move on to the next person, Rama Safadi.
Yeah, I'm going to share my screen. Can everyone see my screen?
We can see your screen.
I'm trying to. Okay, sorry about that. Can you see it now?
Yes, yes.
Okay. So my name is Rama Safadi. I'm a senior at Biomed Science Academy, and I had the pleasure of working with Dr. Rupesh Raina, an adult and pediatric nephrologist at Cleveland Clinic and Akron Children's Hospital. The title of my presentation is Kidney Involvement in Multisystem Inflammatory Syndrome C. Multisystem inflammatory syndrome C is a rare but severe complication in children infected with COVID-19, where symptoms include abdominal pain, rashes, and vomiting. Currently, we have sufficient data in adults with underlying kidney disease, but there's a lack of evidence relating to underlying conditions with severe illness in children. Thus, we decided to complete a literature search between 1946 and 2020 in PubMed to include all studies related to multisystem inflammatory syndrome C and acute kidney injury. A standardized data collection form was used to extract data, and we used Excel and GraphPad Prism 8 for statistical analysis. In total, 1,311 MIS-C patients were analyzed, where the mean age for the study was 9 years old. 56% of MIS-C patients were males and 40% were females. 4% of AKI patients received kidney replacement therapy, and although there has been an increase in published data, the overall population-specific incidence of MIS-C remains unknown, as the relationship between KD and MIS-C are still under debate. Post-viral immunological reaction to COVID-19 remains the best implicated theory behind this disease's pathogenesis, and a better understanding of the kidney physiology in COVID-19 and treatment modalities for children who suffer with renal dysfunction and MIS-C shall help better take care of this subset in adolescents. Thank you for your time.
Thank you. Next is Adam Loco. Adam, are you there?
Yep. Hello. I'm presenting on brain metastases and non-small cell lung cancer. So traditionally, there's very limited treatment options as chemotherapy because of the blood-brain barrier doesn't reach the brain. So patients with brain metastases have a very poor prognosis. However, immunotherapy, in specific anti-PD-1 immunotherapy, is a new treatment for non-small cell lung cancer that has a great improvement in overall survival in patients without brain metastases, but relatively little is known about patients with brain metastases. So we looked at all patients with brain metastases from lung cancer treated at the Cleveland Clinic and saw about a 3-month overall improvement in overall survival when the patients were treated with immunotherapy instead of chemotherapy. In addition, there's a mutation to KRAS that's often seen in lung cancer, and we have no current treatment options for those patients. Patients with KRAS mutations have an increased level of PD-L1, as you see in the bottom, and the patients with a KRAS mutation had a significant improvement in overall survival compared to patients that received chemotherapy. However, if you did not have a mutation in KRAS, there was very little improvement in survival. Therefore, in future clinical trials, we believe it's appropriate to look at KRAS status if you're treating with immunotherapy.
Thank you, Adam. Next is Avni Shah, Brinda Shah.
Hi, okay. Can you all see the screen?
Yes, we can see the screen.
All right. Brenda, do you want to start or?
Sorry, it was muted. Okay. Hello. Today, the topic we've chosen to present is cardiorenal syndrome. This is a condition that occurs as a consequence of the treatment of heart disease. The working definition for this is a decline in renal function due to congestive heart failure. This study discusses the 5 subtypes of CRS and their individual symptoms and possible managements for each type. The subtypes were identified as acute and chronic cardiorenal for CRS1 and CRS2, respectively. The subtypes for CRS3 and CRS4 were identified as acute and chronic renocardic, and CRS5 was identified as secondary.
The treatments of the first 4 subtypes all recommend managements that include diuretic therapies. Specifically, CRS1 and CRS2 also include treatments that manage blood pressure. In addition to diuretic therapies, CRS3 is managed by maintaining the fluid, electrolyte, and acid-base balance. CRS4 is also treated with phosphate binders, erythropoietin, and with maintenance hemodialysis. Finally, CRS5 is managed based on the primary disease and its associated organ damage. This subtype is commonly substance-induced, which can be treated with antibiotic therapies and volume resuscitation. As specialists learn more about this condition in the future, new theories will appear leading to more useful and efficient managements for this syndrome. Because of this, clinicians should be more aware of the condition and seek help from specialists regarding the treatments for CRS.
Thank you so much for listening to our presentation on cardiorenal syndrome.
Thank you. Next is Surisha Mahajan. Surisha, are you there?
Yes, I'm here. Can you see my screen?
And Surisha, you can present both of your posters together.
Okay. Can you see the screen?
Yes, we can see your screen.
Okay. Hello, everyone. My name is Surisha Mahajan, and I'm a senior at Revere High School. Today, I'll be presenting research that I conducted in the Wilson Lab of Biomedical Engineering at Case Western regarding coronary artery calcium scans. So we all know that cardiovascular disease is the #1 cause of death around the world, but a coronary artery calcium scan, or a CAC scan, is one test that can greatly improve risk prediction with a simple CT scan that detects large amounts of calcified plaque in the arteries. Through my literature review, I found that CAC scores accurately predicted cardiovascular risk, especially when they were combined with traditional risk factors such as age or weight. They were most beneficial in reclassifying intermediate risk patients into high or low risk categories. And CAC imaging was also associated with positive lifestyle changes and improved adherence to drug therapy. The Wilson Lab is currently developing a novel calcium scoring method that utilizes multiple specific features of the calcification to produce a more accurate scoring method, which can lead to earlier detection of heart disease and save many lives. So the second poster that I have is on when I was working with Dr. Reyna's research group, and it is a literature review on dialysis disequilibrium syndrome, which is a rare clinical complication that occurs in patients on hemodialysis, and it's characterized by cerebral edema. So in our literature review, we found that there are 3 main ways to prevent or manage DDS. First is changing the mode of dialysis to peritoneal dialysis. Continuous veno-venous hemofiltration or hemofiltration can substantially decrease the incidence of DDS. Second, altering the speed of dialysis by reducing the blood urea concentration from the body at a slower rate can also significantly decrease the risk of DDS. Finally, if replacing the loss of urea with active substrates, such as sodium, which is most easily available, can be used to prevent the fluid shift that leads to edema during DDS. So ultimately, understanding how to reduce and prevent this rare condition can lead to safer dialysis sessions in the future. Thank you for your time.
Thank you, Surisha. Next is Tapat Wanarong. Tapat, are you there?
Yes. Hello. Can you hear me?
Yes. Yes, I can hear you.
Do you want me to present 2 posters at the same time or just one at a time?
No, please present both of your posters together.
Okay. I'm going to share my screen. Can you see my screen?
Yes, we can see your screen. Yes.
So, hello everyone. My name is Tapat Wanarong. I am one of the neurology residents at the University Hospital. Today, I'm going to present my project, which is called Association Between Sarcopenia and Diabetic Peripheral Neuropathy, a systemic review and meta-analysis. So, this study came from a recent popular term called sarcopenia that is used to describe the condition which muscle structure and function decline, mostly related to aging population. And as diabetes is one of the most common non-communicable disease in the current era, we wonder if there is any association between these two entities. So we searched the previous studies, and it seemed like the results are inconsistent. So the aim of this study is to investigate the association between sarcopenia and diabetic peripheral neuropathy by identifying all available studies and summarizing their results. We did an extensive search in both MBase and Medline database, identifying all eligible cross-sectional studies that meet our criteria. Unfortunately, there was no cohort or case control study available. So from over 2,000 studies, we found 4 cross-sectional studies that met the criteria, and we performed the meta-analysis. And from the meta-analysis, the results show a significant association between these two entities. You can see the odds ratio in the figure 2, which is significant. And the number of the study is not enough to demonstrate a publication bias. So in conclusion, our study proved an association between the presence of diabetic peripheral neuropathy and sarcopenia. However, given the summarized data is from cross-sectional studies, so the temporality between these two entities could not be established. Next, I'm going to talk about my second poster. So the second one is the study called statins are not associated with peripheral neuropathy. It is a systemic review and meta-analysis as well. So the study background is from an inconsistent results from the previous studies regarding the association between statins and the risk of developing peripheral neuropathy. Some studies claim that it is one of the cause of peripheral neuropathies, while the other study did not show any association. So the aim of this study is to investigate the risk of peripheral neuropathy among statin users compared with non-statin users. So we did an extensive search in both MBase and Medline database, identifying all eligible cohort and case control studies that met our criteria. So from over 4,000 studies, we found 5 studies, 1 cohort, and 4 case control that met our criteria, and we performed the analysis. The results did not show any significant association between the use of statins and the risk of peripheral neuropathy, as you can see from figure 2. And the publication bias of this study is moderate, as shown in the funnel plot in figure 3. So in conclusion, our study proved that statin is not associated with the risk of peripheral neuropathy. So this helped a lot for the provider who taking care of the patient who is on statin and developing peripheral neuropathy. Thank you for your attention.
Thank you, Thaput. Next is Sanjay Jinka.
Hi, let me screen share here.
Yes, Sanjay, we can see your, is this your screen?
Is it the orange at the top?
Statins?
Is it good?
Statins and the risk of no, that's not your screen.
No.
Thaput, I think that's your screen. So
Yeah, I think he needs to stop screen sharing.
yeah, Thaput, can you please stop screen sharing? Okay. Sanjay, you're on now.
All right, cool. Can you see that?
Yes.
All right, perfect. So, hey, it's Sanjay again. And for this poster, I'll be discussing our research on rhinoplasty for nasal deformities secondary to cleft lip and palate, also known as secondary cleft rhinoplasty. So the goal of this project was to determine what objective post-surgical changes lead to subjective improvements. So to do this, we analyzed 30 photos through a 10-year retrospective review performed by a single surgeon at a single center, this being Dr. Anand Murthy. Photos were blindly rated by members of the clinic, excluding the primary surgeon, with what's known as the UCL SOE scale. In addition to subjective ratings, objective measurements were recorded using the figure here. So figures 1 and 2 show that secondary cleft rhinoplasty led to improvements in subjective and objective outcomes. But for time, I want to focus on figure 3. So here we can see that a decreased columnar angle, increased cleft side height to width ratio, and most notably, increased nostril sill height significantly correlated with improved subjective ratings. This relationship between a defined nostril sill and improved subjective ratings has not been identified before. Further study is required to determine what subjective surgical techniques prioritize this outcome, but this is something we hope to work on in the future. For now, this research is very important as it defines a new parameter for surgeons to be mindful of when performing secondary cleft rhinoplasty. Thank you.
Thank you. Next is Neil Kapoor.
Hello, let me share my screen. Can you see it?
Yes.
My name is Neil Kapoor. I'm an MS3 at NeoMed, and I had the pleasure of working with Dr. Joseph Schwab, the Director of Orthopedic Oncology Service and the Chief of Spine Surgery at Massachusetts General Hospital. The project we worked on was quality of life changes after surgery for metastatic spinal disease, a systematic review and meta-analysis. So it remains questionable to what extent surgery improves quality of life for metastatic spinal disease. It would be interesting to quantify the magnitude and duration of quality of life benefits, if any, after surgery for spinal metastases. For intervention, we looked at surgical indications, including pain, compression, instability, and tumor control. And for our analysis, we used a random effect model to calculate standardized mean differences between summary quality of life scores from baseline to either 1, 3, 6, or 9 months. As you can see in figure 1 in the middle, surgery improved quality of life for patients with spinal metastases in physical, emotional, and functional well-being. Surgery had minimal effect on social and family well-being. Choosing the optimal candidate for surgical intervention in the setting of spinal metastases remains paramount. Otherwise, postoperative morbidity and complications may outbalance the intended benefits of surgery. Future research should report clear definitions of selection criteria and surgical indication and provide stratified quality of life results by indication and clinical characteristics. Thank you.
Thank you. Next is Siddharth Singh. Siddharth, are you there? I'm going to move on to Raman. Raman, are you there?
Yes.
Okay, please go ahead.
Can you see my screen? No, this is not my screen.
Yes.
No, this is a different person. No, this is not me.
He can go before me, that's fine.
So who's presenting right now? Raman?
I can, but I thought the person before me was talking, so I wasn't sure.
Yeah, Raman, please go ahead.
Okay. Okay, can you see my screen?
Yes.
Okay, so hi, my name is Raman Bambra. I'm an M1 at NeoMed, and this past year, I worked at Cleveland Clinic with Dr. Wally, actually. And my project kind of looked at 2 different treatment options for obstructive sleep apnea. We looked at upper airway stimulation and positive airway pressure. And basically we matched the 2 groups on different variables such as age, sex, BMI, and we gave these patients different assessment measures such as the Epworth Sleepiness Scale, Functional Outcomes of Sleep Questionnaire, these mentioned right here. And after looking at the results, we found that both groups had similar improvements in the patient-reported outcomes between the UAS and the PAP patient groups. We also found that in the UAS, which is upper airway stimulation treatment group, there was some greater benefit in those patients that had depressive symptoms relative to the other group. So in the future, we hope to increase sample size and also look at doing different randomized clinical trials to confirm these findings. Thank you.
Thank you. Next is Anmol Kumar.
Yeah, I'm here. Okay. Do you see my screen?
Yes. Yes.
Okay. So hi, my name is Anmol. I'm a third year at Ohio State University, and my presentation is on increased DNA damage and oxidative stress in high-risk prostate cancer subjects. So a major risk factor that contributes to the development of prostate cancer is oxidative stress and the oxidant to antioxidant imbalance. Our goal was to investigate oxidative DNA damage and the changes in antioxidant status as risk factors for prostate cancer. So a total of 40 men without any prior drug or treatment were included in the study. The men were then split into two groups depending on the abnormality of the prostate. Afterwards, an 8-hydroxydeoxyguanosine or 8-OHDG assay was done. So this is a biomarker for oxidative stress and carcinogenesis. We then measured plasma, antioxidant capacity, cyclic GMP, nitrite, and nitrate levels. After that, a GSTP1 assay was performed. So GSTP is an enzyme with an important antioxidant role. This is needed in order to neutralize xenobiotic reactive oxygen. And last but not least, an MGMT assay was also performed. So MGMT is crucial for genome stability as it neutralizes reactive oxygen species by repairing mutagenic methylguanine back to guanine. MGMT is also important for DNA replication and transcription. So after all these assays were performed, measured, and compared, we saw a significant increase in levels of 8-OHDG, cGMP, nitrate, and MGMT activity, coupled with a significant decrease in GSTP levels. This is all indicative that when there is immense oxidative stress and DNA damage present, there's also increased development of prostate cancer. Thank you.
Thank you. Next is Arvind Pavamani.
I'm here. Would you like me to present both posters?
Yes, Arvind, please present both the posters.
Thank you. Can you see my screen?
Yes, we can see your screen.
Okay. Hi, I'm Arvind. I'm one of the PEDS GI fellow at Rainbow Babies and Children's Hospital. I'm going to present my research work looking at the burden of psychiatric and behavioral illnesses in pediatric patients hospitalized with IBD. So the incidence and prevalence of IBD is increasing worldwide, and since it is a chronic inflammatory condition, the comorbid conditions like psychiatric and behavioral illness is also increasing simultaneously. But there is limited data on the pediatric population, so we decided to use a nationally representative sample of the NIS and KID databases to include all the patients with IBD less than 21 years of age and evaluate for the concomitant diagnosis of one of these following 14 diagnoses, psychiatric or behavioral illnesses diagnosis. So what we found was that, as you can see in the figure, the prevalence rate is steadily increasing from 11.3% in 2003 to almost double to 20.6% in 2016, which translates to almost 1 in 5 hospitalized patients with IBD have coexisting psychiatric illnesses. And we also did a multivariate logistic regression analysis with the severity of IBD as an outcome variable. And as you can see, the psychiatric illnesses was increasingly associated with increasing degrees of severity. The intermediate group, severe group of IBD patients had 8% increased chance, but the severe group had 61% increased chance of coexisting psychiatric illnesses. Further, after adjusting for various comorbid conditions as well as IBD-related surgeries, psychiatric illnesses were associated with 1.28 additional days of hospitalization, and they also contributed close to 10,000 inflation-adjusted hospitalization cost in this time interval. So pediatric patients with IBD are at increased risk due to a variety of reasons, due to systemic inflammation, pain, poor quality of life, and also they're often malnourished and have body dysmorphic image issues. So the treating physician should be aware of the coexisting psychiatric illnesses to better manage their symptoms and have a better quality of life. And my next poster is we are looking at the effect of nutritional status in pediatric patients admitted with acute pancreatitis. I'm sorry. Yes. So similarly, the incidence of acute pancreatitis is increasing globally, and in hospitalized patients, we are seeing that increasing proportion of patients with pancreatitis were either obese or malnourished. So there are various prognostic scoring looking at the severity of pancreatitis, but none of them evaluated the role of nutritional status in that predictive modeling. So we included the KIDS national database to include all patients who were admitted with acute pancreatitis. We divided the cohort based on ICD codes into 3 mutually exclusive categories, including undernutrition group, obese group, and patients who are not having any of these 2 diagnoses were categorized as controls for comparison. And as you can see, the proportion of either the undernourished or the obese group is serially increasing. And in 2016, almost 1 in 5 hospitalized patients with acute pancreatitis were either malnourished or obese. And after adjusting for various comorbid condition and etiologic factors and complications, we did the logistic regression analysis with severe acute pancreatitis as an outcome. And as you can see, the undernutrition group is 2.5 times at increased risk of developing severe acute pancreatitis when compared to the control group, and obese group is also 1.6 times at increased risk of developing severe pancreatitis. And similarly, the undernutrition group, the nutritional status itself is an independent predictor of prolonged hospital stay by 6 days in the undernutrition group and by 0.5 days in the obese group. And the undernutrition group also contributed to close to 16,000 additional US dollars in hospitalization charges. And the obese group also contributed to close to 2,000 additional hospitalization charges. So as you can see from our study that both undernutrition and obesity adversely prognosticates the clinical outcomes in pediatric patients with pancreatitis. Our results support the incorporation of nutritional status into the predictive modeling of severe AP in future studies. Thank you.
Thank you. Next is Ananya Thaudi. Ananya, are you there?
Let me share my screen. Can you see that?
Yes.
Okay, cool. So I conducted a retrospective study to update the current medical literature on the incidence rates and survival trends for pediatric thyroid carcinomas. I used the SEER database and looked at all cases for patients aged 0 to 19 that had the diagnosis of pediatric thyroid carcinoma. And the major finds of this related to the 4 most common histological subtypes, which are papillary, follicular variant, medullary, and follicular. And this looked at incidence rates of the diagnosis and was greater in adolescent females. For the papillary follicular variants, this was the most common subtype that we saw, but overall there was an increased ratio of medullary carcinomas in patients under the age of 10. In survival trends, we saw that rates have gradually increased over time, and I assessed the survival rates of patients after having surgery alone and surgery with an adjuvant radiation therapy. And this revealed that treatment methods do not affect children under the age of 10, but they are significantly important regarding kids between ages of 10 and 19. Looking at 15-year disease-specific curves, we saw that patients that are 10 years or younger are not affected, but there is a significant increased survival rate for patients aged 10 to 19 with surgery and radiation therapy. Overall, the early detection and prevention is important in increased survival rates in all age groups and all histological subtypes, apart from medullary carcinomas that are 9 years or more after the initial diagnosis. Thank you.
Thank you. Next is Maitri Mudireddy. Maitri, are you there? I'm going to move on to the next, Ain Shazhan. Ain Shazhan.
Hi. Can you see my screen?
Yes, we can see your screen.
Okay. Hi, my name is Aina. I'm an M2 at NeoMed, and my presentation is on predictors of diabetes technology adoption in patients with cystic fibrosis-related diabetes, or CFRD. Our aim was to determine factors that predict successful implementation of diabetes technology, which we defined as use of continuous glucose monitor or insulin pump for at least 6 months. Factors were compared between patients who had successfully implemented diabetes technology and those who had not. We also compared HbA1c
before and at least 6 months after implementation. Our study was a retrospective chart review of patients with insulin-treated CFRD at a single center. We evaluated 46 patients, of whom 17 successfully implemented continuous glucose monitors and 8 successfully implemented pumps. BMI, FEV1, HbA1c, inpatient admissions, outpatient visits, and insurance type were not significantly different between CGM users and non-users. However, diabetes duration was significantly longer in CGM users. Pump users were not different from non-pump users in terms of BMI, FEV1, HbA1c, diabetes duration, or outpatient endocrinology visits. However, pump users had a significantly lower HbA1c after successfully implementing pump use. We concluded from these results that longer diabetes duration was associated with sustained CGM use. This may also reflect more advanced disease in this group. Our data also suggested that patients with CFRD have improvement in diabetes control after technology implementation, but further research is needed to determine which subset of patients benefits most. Thank you.
Hi, thank you. Next is Hadil Al-Butir. Hadil, are you there? Okay, next is Abdul Al-Harshami Armashi. Please present both your posters. Abdul?
Sure, I will present back to back. I will share my screen now. Can you see my screen?
Yes. Yeah,
Hello
we see
everyone,
you.
I'm
Yeah.
Dr. Armashi. I'm internal medicine resident at St. Vincent Charity Medical Center. I want to really thank AIPNO Research Committee.
Are
for
you able
this
to
great
hear
event. Every year we are
the
very
voice?
excited
Yes, we
to
can hear it,
participate,
yes.
and even with everything we're going through, we are able this year because of the high effort and support from AIPNO to participate, to present our interesting cases, and also to improve our research experience. So today I will be discussing a very interesting case about the rare complications of infective endocarditis that I worked on with Dr. Francisco Somoza. We'll discuss rare complications of infective endocarditis as pneumothorax, sepsis, and heart failure. A little bit of introduction. Infective endocarditis is a common condition seen in IV drug user, and the repetitive IV drug use lead to continuous damage of the endocardium, making the bacterial adherence is more feasible. Once a vegetation has been formed, the septic emboli product can migrate into pulmonary circulation, and it can also lead to the disruption of the lung parenchymas. This will lead to catastrophic life-ending complication as seen in our patient. So our patient is a 31-year-old lady, past medical history of polysubstance abuse, who presented to the emergency department with 1-week history of altered mental status and sudden onset dyspnea. On physical examination, she was hypotensive, tachycardic, diminished breathing sounds, and hollow systolic murmur was heard on the left lower sternal border. Chest x-ray was done, showed a large-sized right pneumothorax. CT was done, showed multiple cavitations of septic emboli, and also showed left-sided pleural effusion. So this patient was admitted to the ICU as a case of septic shock. She was started IV fluid, broad-spectrum antibiotics, and a chest tube was placed, and it was draining purulent material bilaterally. A TEE was done. It showed 2.5 centimeters large-sized vegetation on the tricuspid valve, also showed severe tricuspid regurgitation, and the ejection fraction was 50%. The patient was stabilized and she was sent to regular nursing floor for monitoring, but unfortunately after 24 hours she severely decompensated, which required vasopressors again and intubation. A repeated TEE was done and showed decreased ejection fraction to 20 to 25%, and cardiothoracic surgeon was consulted for immediate valve repair, but due to her high mortality, high morbidity risk with severe pulmonary compromise, the procedure was cancelled, and the patient was transferred to long-term acute facility for long-term antibiotic administration, but unfortunately she expired after 2 cardiac arrests. This case illustrates the potential life-ending complications of late presenting infective endocarditis, promote evaluation by cardiothoracic surgeon might be life-saving, and more research is warranted in this type of patients. Thank you so much.
Now I will go to the case
Hello
number
everyone,
two.
this is Dr. Armashi, second year internal medicine resident. I want to thank AIPNO again for this amazing event, and I have a very interesting case to present today. So the title of my poster is Interferon Beta Causing Focal Segmental Glomerulosclerosis in Patient with Multiple Sclerosis. So introduction, we know that interferon beta is the first choice treatment for patients with relapsing remittent multiple sclerosis. As we know, interferon beta has multiple side effects, and we will discuss a very interesting one seen with our patient. Our patient is a 53-year-old lady, past medical history of multiple sclerosis, diagnosed 12 years ago. She is on interferon beta, who presented to her nephrology clinic as her routine labs showed elevated serum creatinine. On physical examination, she was having bilateral ankle swelling. Lab work showed elevated serum creatinine, elevated BUN, low albumin, and high level of cholesterol. Urine analysis was done, showed heavy proteinuria, protein creatinine ratio of 4.8, heavy albuminuria with albumin creatinine ratio of 3.5. The patient got renal ultrasound, showed increased the echo in the right cortex of the right kidney. Renal biopsy was done and confirmed glomerulopathy with moderate glomerular sclerosis, segmental foot effacement, renal tubular injury, and microvillus changes. Due to absence of the usual risk factor for focal segmental glomerulosclerosis, a presumptive diagnosis was made that these findings are related to interferon beta. The offending drug was stopped, and the patient was started on steroid and immunomodulators, and she came back after 6 months with kidney function as baseline and improved. So this case illustrates a rare side effect of interferon beta. The physician should draw attention to signs and symptoms of nephropathy in patients under this medication, as routine follow-up labs do not include urine analysis and renal function panel. Thank you so much.
Thank you, Dr. Gupta.
Thank you. And lastly, we have Brian Margaria. If I pronounce it right, I'm
Yep,
sorry.
I'm here. Give me 1 second, please.
Yeah, Brian, please.
Yep. Okay, can everyone see this?
Yes, we can see your screen now.
All right, sweet. So this is a case of a 64-year-old Caucasian male who was recently diagnosed with prostate cancer, who presented to an academic hospital with headaches, leg restlessness, and a 25-pound weight loss, as well as hypercalcemia discovered on screening labs. Upon admission to the hospital, the patient in question was found to have hypercalcemia, anemia, and acute renal failure, symptoms suggestive of multiple myeloma. Further workup it revealed an equivocal SPEP and UPEP, with multiple myeloma being considered the most likely diagnosis at this time. Additionally, vitamin D levels in this patient were low, and a PTH and PTH-related hormone were low/normal. However, a CT of the abdomen/pelvis revealed incidental finding of hilar lymphadenopathy suggestive of sarcoidosis. Patient later had a biopsy confirming the diagnosis and had an excellent response to steroids. This case is unique as the low levels of vitamin D and PTHRH would suggest other diagnoses, and the patient had no long symptoms suggestive of sarcoidosis. An important lesson is to always have a broad differential when considering patient presentations, as classic illnesses can have atypical presentations. Thank you very much.
Thank you, everybody. I really want to thank you all for all this great presentation. It was awesome, and we all had opportunity to hear all the presentations. And may I request all of you now to please join the main session, and our main event has already started, and we will be announcing the winners soon.